Welcome back to another episode of High Yield Heme. This time we're talking about hemostasis, clotting, coagulation, the related pharmacology and conditions and all that jazz. Let's see how we go. Our first concept is hemostasis, stopping blood flow when there is an injury. So when there is an injury, there is reflex vasoconstriction of the smooth muscle to reduce blood loss. The damaged vessel releases chemicals and then platelets come along, adhere, activate and aggregate, forming the primary platelet plug. Then coagulation, this guy over here, activates with the goal of turning fibrinogen into fibrin and producing a clot. Let's take a closer look at the coagulation pathway. I'll break it down even simpler in the next slide, but the key takeaways are the extrinsic pathway on this side is activated by extrinsic or outside damage. It requires tissue factor, and if you think about it, tissues are outside the blood vessel. The intrinsic pathway is activated by the damaged surface and is the longer pathway. Both lead into the common pathway down here, producing thrombin, which turns fibrinogen to fibrin. And when prothrombin is cleaved to form thrombin, it actually activates and amplifies other clotting factors and cofactors. Also, make a note of these guys in red. These are essentially natural anticoagulants, things like antithrombin, protein C, protein S, and they inhibit coagulation. So, this leads me to talk about some hereditary conditions. Hereditary thrombophilia is a tendency to clot too much. This can be due to a deficiency of anticoagulant proteins, which we just talked about, or a mutation that increases tendency to thrombosis, such as if you have more clotting factors. Factor V Leiden is the most common genetic mutation, which confers resistance to active protein C. On the other hand, hemophilia is a tendency to bleed too much because of inadequacy of coagulation. And the two important ones to remember are hemophilia A, a deficiency of factor 8, and hemophilia B, a deficiency of factor 9. I remember it as A for 8 because they sound similar. Okay, so let's talk about memorizing the coagulation cascade. I start with the common. And remember factors of 10 in descending order. 10 divided by 5, 2, then 1. Extrinsic is just 7, nothing too hard. Maybe remember 7 looks like T for tissue factor. Intrinsic, I count down from 12 and skip 10 because it's in the common. So 12, 11, 9, 8. Vitamin K dependent factors, you've heard it before, but think Australian TV channels. Okay, hopefully that made it easier. There are also a few anticoagulant medications you need to know. First off, let's talk about warfarin. This is a vitamin K antagonist, so it works on the clotting factors we just talked about. Warfarin is teratogenic and it also requires monitoring of the INR, which I'll discuss more soon. Heparin works via antithrombin 3 and makes it more potent, acting on factor 10 and thrombin. This one's okay in pregnancy. Low molecular weight heparin is also called enoxaparin and it has a longer half-life than heparin and is given subcutaneously. It can also be used to bridge therapy. The newer ones are the factor 10 inhibitors, apixaban and rivaroxaban, which does what the name suggests, and dabigatran, which is really good because it is similar in efficacy to warfarin, but doesn't require INR monitoring. You choose which drug you use depending on a whole range of factors. These days, DOACs are used more unless there are contraindications, such as mechanical valves or renal impairment, in which case you might go for warfarin instead. I mentioned coagulation studies. These look at how quickly blood coagulates in the lab and can help narrow down which factors or inhibitors are deficient or elevated. APTT tests the intrinsic and common pathway, thrombin time, the common, and PT, the extrinsic and common. INR stands for International Normalized Ratio and is essentially prothrombin time, but just a way to standardize testing across all labs in the world. Finally, you might also hear about a mixing test. In this test, we mix the patient's plasma with normal control plasma. If it corrects, this suggests that there is a factor deficiency and the factors in the control plasma made up for it. If there is no correction and the time remains elevated, this suggests there is an inhibitor present in the patient's plasma. Next, let's talk about Virchow's triad. These are factors that predispose to the formation of clots and can lead to DVTs, clots in veins, typically in the leg and pelvis, and PEs, clots in the lungs. let me introduce you to a 65-year-old lady who's just had a hip replacement and has a background of smoking, hypertension, obesity, and breast cancer. It's not a great case, but let's just use it to highlight how Virchow's triad is applicable. So when we think of factors that might lead to a clot forming, we think of Virchow's triad: stasis of blood flow, endothelial injury, and hypercoagulability. Stasis of blood flow. Well, a patient lying in bed after a major surgery leads to stasis. Other things could include immobility, varicose veins, long-haul flights, or atrial fibrillation. Endothelial injury. Well, she's just had a major surgery. Other causes could be trauma or invasive procedures such as cannulation or even high blood pressure. Finally, hypercoagulability. Smoking and cancer can cause hypercoagulable states, as well as hereditary conditions that we talked about earlier, like factor V Leiden. Antiplatelets. You'll see them everywhere, and I'll talk about 3 key ones quickly. Firstly, aspirin, which irreversibly inhibits the COX enzyme and decreases thromboxane, which decreases platelet aggregation. Clopidogrel inhibits ADP-induced activation of platelets by inhibiting binding of ADP to platelets P2Y12 receptors. Dual antiplatelet therapy usually refers to aspirin and clopidogrel or similar drugs used together. Finally, apixaban is a glycoprotein 2 B3A receptor antagonist. I'll also mention von Willebrand's factor here, mostly because I have this nice diagram. It's made by endothelial cells lining surfaces of blood cells. When there is an injury, collagen binds to von Willebrand factor, which then allows platelets to bind. It's also a carrier for clotting factor 8, so a deficiency can lead to mild or moderate bleeding. This usually has minimal treatment, but if severe, you can infuse concentrated von Willebrand factor from purified human plasma. Factor 8 is in the intrinsic pathway, so you might see a mildly prolonged APTT, but INR and platelet counts would be normal. Okay, home stretch. Fibrinolysis occurs after the clots are formed and you now need to get rid of the fibrin. Plasminogen is cleaved to form plasmin, which then breaks fibrin down to its degradation products. A marker of fibrinolysis is D-dimers. In disseminated intravascular coagulation, you'll see high levels of circulating D-dimers, as there is excess clotting, which uses up platelets and clotting factors and then leads to excess bleeding. It can be triggered by any precipitating event, including infections, trauma, cancer, so on. Pharmacologically, we've talked about anti-platelets and anticoagulants. The anti-fibrinolytic drug to know is tranexamic acid, which inhibits plasminogen conversion to plasmin and stops fibrinolysis, so can treat heavy bleeding in the short term. On the other hand, to trigger fibrinolysis, we use fibrinolytic agents. The main one is alteplase, which is recombinant human plasma tissue plasminogen activator. And you'll see this used in acute myocardial infarctions or STEMIs to break down clots. So this brings us to the end of our talk on bleeding, not bleeding, stopping bleeding, so on. Check out our other videos and ask us if you have any questions. See you next time.